right, well, hopefully you've got your cup of coffee or tea and you can settle in and enjoy today's program, as we've got some great speakers lined up for you today. And with that, we'll go ahead and get started in today's program. Hello and welcome to the Minnesota and Dakotas chapter, New Frontiers in Research and Care. I'm Erin McGee, a program manager for the chapter of the Parkinson's Foundation. Today's program is being recorded. Attendees will receive a follow-up email with the recording, slides, and other resources. After today's program, we greatly appreciate taking just a few minutes to share your feedback of today's program on the survey that will open as the Zoom webinar ends. Before we begin today, I want to welcome those of you who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. We make life better for people living with Parkinson's by improving care and advancing research toward a cure. We have everything you need to live better with Parkinson's. To achieve our mission, we pursue three goals: to improve care for everyone with Parkinson's, to advance research toward a cure, and to empower and educate our global community. And we do all of this building on the energy, experience, and passion from our global Parkinson's community. Our signature fundraising event, Moving Day, a Walk for Parkinson's, is coming up. 74 days to be exact, on Saturday, May 1st here in Minnesota. This nationwide event has raised more than $30 million to support the mission by delivering quality care, funding research, and providing free resources and local services. Moving Day will look a little different this year, but our commitment to making lives better for people with Parkinson's has not changed. My colleagues are planning a virtual option and a drive-through event here in Minnesota. Visit movingdaytwincities.org to learn more. I'd also like to say a big thank you today to our sponsor, Amneal, whose generosity has made this program possible. Thank you, Amneal, for all your support. To learn more about Amneal and the resources they offer the Parkinson's community, including detailed product information, please visit our virtual exhibit hall located at parkinson.org/Minnesota-Dakotas/chapter-supports. When you visit this page, all you need to do is click on the sponsor's logo to find out more information. You'll also get the link in your follow-up email to learn more about them. All right, let's settle in, and I'm excited to introduce our first speaker, Dr. Martha Nance. She is the medical director at Struthers Parkinson Center, located in Golden Valley, Minnesota, and also a Parkinson's Foundation Center of Excellence. Dr. Nance went to Yale University and Virginia Commonwealth University before making her way to Minnesota for her neurology training in the mid-1980s, and she has been here ever since. She has been the medical director of Struthers Parkinson Center since 2000. Let's welcome Dr. Nance. Good morning, Dr. Nance.
Good morning. So here I am. Well, thank you so much, Erin. It's such a pleasure to come speak to this group. I think I spoke maybe a year ago about genetics and Parkinson's disease, and it's kind of nice to give the update a year later. So I decided, we're always supposed to tell people what our disclosures are, and the only relevant disclosure I have for today is that I am an enthusiastic investigator and actually a member of the steering committee for a study called PD Generation, which is funded by the Parkinson Foundation, and which I will talk about during the course of the presentation. I decided this time to give the same presentation that I gave to a bunch of doctors a month ago. I think you can handle it. And I really do think that both people with Parkinson's and families and doctors need to have the same understanding of genetics, and we're all kind of getting up to speed on it. So what I started with in my talk to the docs a couple months ago was, here I am in clinic, here are my next 4 patients. So who are they? Well, I've got Philip, who's 32 years old and had the onset of Parkinson's 3 years ago, mostly affecting gait, a little bit of tremor, responds well to levodopa. He has a 40-year-old brother who also has Parkinson's disease, and they think that they're of sort of European ancestry. After Philip, then there's Christine, who's 63 years old, has had Parkinson's for a few years, maybe 5 years, and is now already developing some cognitive changes. Her grandmother and probably an uncle had Parkinson's, or maybe it was Lewy body disease. She actually had a gene test through a company, a direct-to-consumer company called 23andMe, and her test results were negative. Eli is next on the list. He's 65 years old and has just referred for confirmation of the diagnosis of Parkinson's. No affected family members. He is of Ashkenazi Jewish ancestry on his father's side and African American on his mother's side. And then there's Paul. I probably see about 50 Pauls a week. Paul is 70 years old. He's just coming for routine follow-up of ordinary Parkinson's disease, responds well to levodopa, diagnosed maybe 7 or 8 years ago. He's heard the buzz about genetic testing and wants to talk about it. He has no family history of Parkinson's, and he, like, 50% of the patients I see, or maybe 80% of the patients I see, he's of Scandinavian and European ancestry. So why would I think about genetics at all as I'm seeing the next few patients? Well, in particular, Philip kind of comes to mind as you think, does anybody in this group have a genetic form of Parkinson's? Well, Philip is young, onset age under 30. He has an affected sibling. Nothing unusual about his ancestry, but just the young onset and the affected sibling makes you say, this could be genetic. And if you're thinking like a geneticist, you would say, well, if there are 2 siblings affected and nobody in prior generations, that's quite likely a condition inherited in what we would call a recessive manner, which we won't talk about a whole lot, but I'm already sort of thinking in genetic terms as I go in the room to see Philip. And then whenever you have an affected sibling in a family, and you think that there's a family disease, a genetic disease, you think both how Parkinson-like is the patient's phenotype, how much does their condition really seem like plain old ordinary Parkinson's disease, but you can also think about the sibling. Does the sibling have something that really seems like plain old ordinary Parkinson's disease? Or is there something a little bit different about the symptoms that the sibling has? Are there other family members who have neurologic diseases that may be sort of not quite sure what it was? So the minute you start thinking about a genetic condition, you can sort of broaden out and say, what are all the symptoms in all the family members? Because there are some genetic conditions that may have Parkinson-ish features in some family members, but have other neurologic symptoms in other family members, like dystonia or ataxia. And as I'm trying to figure out what's the family disease, I can broaden out my thinking to include the siblings as well as the person in the room in front of me. Here is the dreaded slide of genes and that have to do with Parkinson's disease. Over on the left hand are the names of these different genes: GBA, LRRK2, DJ1, PINK1, Parkin, synuclein, VPS13C, and VPS35. There are 8 genes on this list, and 7 of the 8 genes are ones that we are including in our testing panel in the PD gene study that I'll talk about throughout this presentation. The one that we're not doing is VPS13C, which, if you look in the second to the right-hand column, is quite rare. There are descriptions over on the right-hand side of, sort of special things, either about the symptoms or the progression of the disease. And MOI means mode of inheritance. That's that recessive or dominant that I mentioned a minute ago. And this is taken from a resource called Gene Reviews, which is an online resource that I encourage doctors to use. And it's actually reasonably accessible, I think, to patients as well. There are some big words in there like phenotype and heterozygote and things like that. But there are, this particular thing is an overview of genetic forms of Parkinson's, which you can maybe look at and see whether it helps give you sort of a decent background about genetics and Parkinson's. There are other, quote, Parkinson's genes. So bullet point 1 is kind of the next 7 genes that are maybe the next least rare. The second bullet point I put in parentheses. I think these are genes for which there's some current discussion or argument. Are they really genes in which a mutation can cause Parkinson's? Maybe it's been seen in one family, but hasn't been confirmed in any other families. And then there are genes that can be responsible for conditions that might look a little like Parkinson's in a given person. So I mentioned earlier that dystonia is sort of a slightly different condition that may look a little like Parkinson's in a given person. So dopa responsive dystonia or generalized dystonia. Some of the hereditary ataxia conditions can have some Parkinson features in some patients and so on. So one of the challenges that the doctor is going to have, I'll talk about more in a minute, is which gene do you even test for, or which genes do you test for if you see a patient who might have a genetic form of Parkinson's? But the first question is, why would you even do a gene test in a person with Parkinson's disease? And I will sometimes in this slide, just to abbreviate, I will refer to a person with Parkinson's or people with Parkinson's as PPD. I will usually refer to them as people with Parkinson's or sometimes patients. And I apologize if I refer to people with Parkinson's as patients. That's sort of thinking like the doctor thinks. But I'm accustomed to phrasing it that way. Why do a gene test in a person with Parkinson's? Well, number one is just to understand why. Wouldn't you like to know why you have Parkinson's? Number two would be if it makes a difference in terms of the prognosis. If Parkinson's due to a mutation in gene X is a milder form of Parkinson's, or if Parkinson's due to a mutation in gene Y is a more rapidly progressive form of Parkinson's, that's important to know, even if it's bad news, certainly if it's good news. Obviously, it would be important to do a gene test if it makes a difference in terms of treatment. And then the fourth reason to do a gene test would be to clarify the risk to other family members. So let's talk a little bit more about each of those. Understanding why. Well, for the person with Parkinson's disease, finding a gene mutation answers the question, why on earth did I get Parkinson's disease? I'm quite sure that there are 100 people on this call who are wondering, why on earth did I get Parkinson's disease? Now, obviously in the research lab, finding a gene whose mutation all by itself can cause Parkinson's disease, well, that must be a gene that's really important in the nerve cells. Why is it important in nerve cells? What happens if that gene has a typo or a mistake or a mutation in it? This provides ample fodder for basic researchers who want to understand the mechanisms that lead to Parkinson's or treatments that might alter those mechanisms or return them to normal. So obviously finding a gene is really important it's an important lead for the basic science researchers. To the patient, it answers the question, why did I get Parkinson's? And we now think that maybe 10% of people with Parkinson's will turn out to have a form of Parkinson's caused by a specific mutation in a specific gene, what we would call monogenic. One mutation in one gene caused Parkinson's. Now that obviously means that 90% of people that we test will turn out to have normal gene test results. But if I've got 2,000 patients coming to my Parkinson's clinic at Struthers, and 200 of them have an identifiable cause for their Parkinson's, well, that's a fair number of people who could actually get an answer to the question, why did I get Parkinson's? So number two, as I said, would be the impact on prognosis. I've been saying this for a few years in public, and I will keep saying it. One of the genes that we're testing in this PD gene study is a gene called Parkin. People who have mutations in both copies, both the mother's copy and the father's copy of the Parkin gene, people who have mutations in both copies of the Parkin gene will develop Parkinson's disease with a very young onset, under age 30 typically, or certainly between 30 and 40, often have more gait trouble, kind of a stiff or almost spastic gait. People with Parkin mutations do not lose their sense of smell, which is a common feature of sort of idiopathic, ordinary garden variety Parkinson's. Parkin-related Parkinson's disease has a very long, slow course. People live into their 60s, 70s, 80s after the onset at age 30. They have little or no dementia. And interestingly, if you look under the microscope, you don't see Lewy bodies in the degenerating nerve cells. Lewy bodies are the pathologic or the histologic hallmark of Parkinson's disease. So here's a condition that has a completely different onset age, different pathology, different symptoms. And I think it's time, let's don't call it Parkinson's disease, let's call it Parkin-related, Parkinson-like disease. So that clearly, I think, is a condition that has a sort of a milder course than the typical average Parkinson's disease. I put in gray some comments about GBA-related Parkinson's and synuclein-related Parkinson's. We're not quite as ready to say this out loud, but there's some hint that some mutations in GBA may lead to a more rapidly progressive course, or a course of Parkinson's that's a little more likely to have dementia earlier on. And synuclein probably does cause what in neurology we would call more of a multi-system degenerative process that also includes dementia as an earlier feature. So there's a hint that GBA and synuclein-related Parkinson's disease may have a more rapidly progressive course or have more symptoms than the typical case of Parkinson's. The challenge with that is there are multiple different mutations that can be detected in GBA or synuclein. It's not clear that every single mutation that a patient might have always causes a more rapidly progressive course. So this is a little more complicated to discuss. And so I kind of put it in sort of shades of gray at this point, not black and white. What about the impact of genetics on treatment? Well, as of today, there is no pill that you do or don't take because your Parkinson's is or is not related to a mutation in the Parkin gene or a mutation in the GBA gene. But for two of these genes, GBA and LRRK2, there are now clinical trials being proposed or underway that are looking at treatments specific for those genetic forms of Parkinson's. So this is a table taken from a review article by Dr. Roy Alcalay, who's actually the lead investigator in the PD gene study that I've referred to a couple of times. So there are at least 5 different companies that are working on treatments that are specific for Parkinson's disease caused by a mutation in the GBA gene. Unfortunately, there's a big X here. One of these trials, it was just announced earlier this month, failed. So the treatment was not shown to have any beneficial effect in people with GBA-related Parkinson's. So this particular treatment didn't work. There are still several other companies working on different kinds of treatments that would be specific for that genetic form of Parkinson's. And the other one is the LRRK2 related Parkinson's disease. Again, 5 different companies looking at different ways to treat Parkinson's disease that is specifically related to a LRRK2 mutation. Interestingly, the mutations, so the LRRK2 gene encodes or is a recipe for a kind of protein that's an enzyme called a kinase enzyme. And a lot of the drug companies have libraries. Believe it or not, there's actually libraries of chemicals. I have libraries. I'm at home today. This is libraries of my cookbooks sitting behind me. But drug companies have libraries of chemicals. Kinases are a kind of enzyme that are commonly used in cells. It turns out that mutations in the LRRK2 gene that cause Parkinson's all seem to lead to overactivity of that kinase enzyme. And these drug companies are full of chemicals in their libraries that are kinase inhibitors, kinase blockers, to sort of slow down that overexuberant kinase enzyme. So it was pretty easy for several companies to say, well, I've got a product sitting on my shelf that is a kinase inhibitor. Let's see whether it effectively blocks the effects of this enzyme that seem to lead to Parkinson's. So stay tuned for results of these studies. And if you turn out to be somebody who has a GBA mutation or a LRRK2 mutation causing your Parkinson's, you might be able to participate in a research study to push back the frontiers to develop a treatment specific for that form of Parkinson's. So no change in the treatment yet, but possibility of a change in the treatment or a new treatment that's specific for those genetic forms of Parkinson's. What about clarifying the risk to relatives? Well, the party line, what we usually say to people is, my risk of getting Parkinson's, or the man on the street in the US, a US Caucasian, has a 3 or 4% risk of developing Parkinson's by age 80. If you have a first degree relative, a parent, a child, or a sibling who has Parkinson's, that risk doubles. You have twice the risk of getting Parkinson's as the average person, but that means it doubles to 6 or 8%. So still a pretty low risk, although it's double my risk of 3%. But if your parent has a genetic form of Parkinson's, synuclein, GBA, LRRK2, one of these what we would call dominantly inherited conditions that where the gene mutation directly causes Parkinson's, everybody has 2 copies of each gene in your cells, because 1 copy of each gene came from mom, 1 copy of each gene came from dad. In the case of GBA, LRRK2, synuclein, all you have to have is 1 copy of the gene that has a mutation, a typo, and then you get the disease, even though the other copy of the gene is normal. Well, when that person has a child, each child's chance of inheriting that gene with the typo, the gene with the mutation, is 50-50. It's a flip of a coin. Any given egg or sperm cell either has the mutated copy of the gene or the normal copy of the gene. Well, that's a major difference in risk, from 6% to saying that you have a 50% chance of inheriting your parents' dominantly inherited genetic form of Parkinson's, the gene that causes that form of Parkinson's. If it's somebody who has Parkin-related Parkinson's disease, as I said, for that particular kind of Parkinson's, you have to get a double hit. Both copies of the Parkin gene have to have a typo or a mutation in order to lead to that young onset form of Parkinson's disease. Well, if the parent has both copies of the gene have a mutation, then when that parent goes to have a child, whichever copy of the gene they give to the child, it has a Parkin mutation in it. So all of that person's children are going to be carriers of a pathogenic mutation. The challenge is, and I put 4 stars next to this, for a currently unaffected individual, the relationship between having that gene mutation and developing Parkinson's disease is complicated to explain. What does that mean? Well, what does it mean to have 1 copy of a Parkin mutation? I told you it takes 2 copies of a Parkin mutation to lead to young onset Parkinson's. What if you have 1 copy of a Parkin mutation and your other copy of that gene is normal? We're not quite sure what that means. There's some thought that it may increase your risk of getting Parkinson's disease slightly. It's not a single copy of a Parkin mutation is not going to cause young onset Parkinson's disease. What if you have a single copy of a GBA mutation? We do think that that can cause Parkinson's, but it doesn't always cause Parkinson's. So explaining to a given individual who doesn't yet have Parkinson's disease what it means to have a Parkinson's gene mutation is complicated. And you should not assume that as an unaffected person, as the child of an affected parent, if you have a gene mutation, that means that you will 100% for sure get Parkinson's. It may not at all be 100% for sure. So you really need some counseling. And part of the point of the PD gene study is to bring doctors up to speed, to include genetic counselors in really helping us explain what these gene test results mean, not only to the person who has Parkinson's, but helping those people to understand what to say to their family members. So enough sort of musing and thinking. Back to the clinic. I got Philip and Christine and Eli and Paul waiting to be seen. What do I do with those folks? Well, as you start thinking about doing gene tests, there are other things that the doctor has to consider. Which gene do you test for, or which genes? Laboratories often offer gene test panels, but not all test panels are created equal. So for instance, in this PD generation study, we are looking at 7 different genes, which we think are the top 7, the most common 7 genes that are related to Parkinson's. There are other companies that test more or less. So there's a company that tests 20 different Parkinson's genes. The 23andMe that I mentioned, where Christine, a test in the past done by a direct-to-consumer company called 23andMe, her gene test was negative. Well, 23andMe looks at 1 mutation in the LRRK2 gene, 1 mutation in the GBA gene, and that's it. So that's what she was tested for before. So what were you tested for before? What genes were included in your gene test panel? The cost to the patient is another issue. So insurance, in its infinite wisdom, often will not cover the cost of genetic testing because it doesn't matter. One of the things we're hoping to change during the course of the PD gene study is the attitude of not only doctors, but also insurance companies, the idea that it does make a difference and that you should cover the cost of insurance. And as more gene tests are done, the cost of testing is also coming down as the years go by. And then I think the doctor doing the gene test needs to understand, I always say that the unit of care in genetics is really the family. The unit of care in most of what we do in neurology is the individual patient. But the minute you do a gene test, the results of that test may have an impact on the brother, the sister, the children. And whoever's doing that gene test needs to either be able to address questions about from family members, at least know where to direct family members to someone who can answer their questions. As I said, PD Generation is an effort funded by the Parkinson Foundation to bring genetic testing to the clinic, to get people tested, and to get Parkinson neurologists familiar with and able to explain to patients the genetics of Parkinson's. So back to the clinic. What would I do next? Well, I think Philip, with young onset Parkinson's, he is likely to have Parkin-related Parkinson's disease, which would be caused by mutations in both copies of the Parkin gene. The minute you say Parkin gene, both DJ1 and PINK1 are less common genetic forms of Parkinson's that present in a very similar way to Parkin. And so his gene test panel certainly needs to include those 3 genes. And because many different mutations in the Parkin gene can lead to Parkin-related Parkinson's disease, his gene test panel probably needs to sequence the Parkin gene, or whenever you see the word sequence, it basically means you need to look at every single word, every single letter in the Parkin gene to make sure every single word is spelled correctly, and not just look at sort of a hotspot or a common location for mutation, as for instance is done in the 23andMe panel. Christine, I think her story is pretty consistent with a dominantly inherited condition. Her grandparent has it, her uncle has it, and it's progressing somewhat more quickly than average with early onset of dementia. This could be a GBA-related form of Parkinson's, or it could be a synuclein-related form of Parkinson's. Both are genes that in the laboratory are somewhat complicated to test, and some Parkinson's panels do not include GBA. So I had a patient who we tested through the PD gene study, who said, well, my sister has Parkinson's and she already had a big gene test panel that included 20 different genes. But I'll be in your study anyway. Her testing was normal. So I don't really think it's genetic, but I'll participate in your study anyway. And this person turned out to have a GBA mutation. And as I was discussing his results with him, he had his sister's test results in front of him and he said, her panel did not include GBA. So it included 20 different Parkinson's genes, but not the most common one, not GBA. So you have to be careful about what genes you were actually tested for. And then in Eli, I think it's pretty reasonable to test virtually anybody who is of Ashkenazi heritage for GBA and LRRK2. GBA mutations are present in up to 20% of Jewish people with Parkinson's, and LRRK2 variants are present in up to 10% of Ashkenazi people with Parkinson's. And by the way, these are the genes for which clinical trials are starting up. So if you have a GBA or LRRK2 mutation, you might be a candidate to participate in a trial of a specific gene to treat that form of Parkinson's. So even without a family history, I might test Eli for GBA or LRRK2. And Eli's mother, remember, is African-American. And this is partly to point out we know absolutely nothing about the genetics of Parkinson's in sub-Saharan Africa. There are some initiatives to try and fix that gap, but at the moment we know very little about the Black African genetics, Parkinson's genetics. And Paul, as I said before, I must see about 50 Pauls a week. Scandinavian, Minnesotan, 70-year-old people with pretty much average Parkinson's, no family history. What I would say to Paul is there's a 90% chance that your test panel will be normal. Doesn't mean you don't have Parkinson's, just means that you don't have Parkinson's due to a mutation in gene X, Y, or Z. And then I go down to the second big bullet point. There's a 10% chance your test panel will show a gene mutation. And not to say that you shouldn't get tested, but understand once we find a mutation, once we do a genetic test, we're really straying into genetics where the unit of care really is the family and not the patient. Your gene test results will have immediate implications for your siblings and your children. They may not be, I'm always excited when somebody has a gene mutation. Yes, now I know why you have Parkinson's, but your children or your brothers and sisters may not be quite so excited about your gene test result. Not to say you shouldn't have it, but just understand that they may not be quite as thrilled as you are to know about your genetics. What if Paul's gene test is negative? I think a lot of people then start to say, well, okay, is my Parkinson's more likely environmental? Maybe it is. You know, the best I can say is we're now able to tease out that 10% of people who do have a specifically genetic cause of Parkinson's. The other 90% still say, well, I'm not sure why I have Parkinson's. Maybe it's a little more likely environmental, but there are additional genetic risk aspects to Parkinson's that remain to be understood. There may be many genes that slightly increase the risk of Parkinson's. So for instance, if my mother is 6 feet tall and my father's 6'4", I'm not so surprised if I'm tall. Versus if my parents are 5'6" and 5'8", that would be pretty surprising for me to be tall. There's not a single gene that causes people to be tall. It's probably a bunch of different genes. And if you're in a family where there's people with Parkinson's and you don't have a specific gene mutation causing the Parkinson's, there may still be genetic background risk. And studies, the kind of studies that look for this are called GWAS studies. And the most recent analysis of all the GWAS studies shows there may be up to 90 different genes that slightly increase or slightly decrease the risk of Parkinson's. Another comment is that laboratories, as they start reading all these genes in all these people, are quite likely to find typos. So, and how do you know if a typo is significant or not? So the analogy I can think of, I had a student in my clinic the other day whose last name was Favor. And I was trying to, I'm getting bad with names. So I wrote down her name so I would remember it. And I wrote down Favor. Then I looked up at her name tag and her name was spelled Favor. And, you know, so I had made a typo. I had deleted that letter U from her name when I wrote it down on my sheet of paper. Well, does it really matter? The word is pronounced the same, whether it's Favor or Favor. And she still looked up when I pronounced the word favor, spelled with just the OR. So that may be a variant in the spelling of her name that really doesn't make a difference. Now, if I change the V to a T, then all of a sudden I have something that's pronounced Fator. Well, that doesn't sound right. That's a mutation. That's a typo that is significant. She's not going to respond if I call out the name, you know, Laver or Fatter. She's not going to respond to that. So laboratories often detect this. They see typos in the genes that we're not quite sure if that makes a difference or not. We've never seen that typo before. We don't know if it causes Parkinson's or not. In the lab, they call those variants of uncertain significance. And it may be that we'll eventually learn, even as part of the PD gene study, that we find that typo in 20 different people with Parkinson's, and we think that it is important. Does the laboratory need to contact us? Do we need to contact the patient as we learn more? This is a rapidly changing area in medicine. And some laboratories report variants of uncertain significance. Some laboratories don't. So this is also something that the doctor, the patient sort of has to think about as they get a gene test. So, and the Parkinson's, the genetics of Parkinson's is complicated. Paul, the person I'm describing, turned out to have a mutation in the GBA gene and a mutation in one copy of the Parkin gene. So trying to explain that to this guy who's just an average guy with Parkinson's disease was sort of interesting. So what have we learned from the PD generation study? We've now had over 600 people enrolled at 6 pilot sites, now opening to additional sites with the goal of enrolling 10,000 people in the study. During COVID, we switched from a fully in-person protocol to either partial or fully telemedicine enrollment. I'll show you in the next slide the results of 525 gene test results that we knew by the end of 2020. And the other comment I make is the interest in the Parkinson's community in this study is really high. The sites are overwhelmed with people wanting to participate. So what have we found? We found 89 different gene mutations in 78 different patients. The majority, over 50% of the mutations were in the GBA gene. And we saw 13 different typos, 13 different misspellings of that word. The next most common was Parkin, where there were 12 different mutations in the Parkin gene identified. Remember, you have to have an abnormal result in both copies of your Parkin gene in order to get young onset Parkinson's. We don't know what to tell people who have a mutation in one of their 2 Parkin genes. We don't know if that increases the risk of Parkinson's. It probably does not directly cause Parkinson's, but it's a slightly difficult thing to counsel people about. And then several people with LRRK2 mutations, and then a few people with synuclein mutations. So if you look at this a little more carefully, you'll realize 78 patients out of 525 is about 15%. That's higher than the 10% that we usually tell people. I think that's simply because the kind of people who are enrolling in PD generation are people who are maybe a little more likely to have a gene mutation. They have a family history of Parkinson's, or they've already had a gene test somewhere else. So so slightly higher rate in this study than in the general population. And then in the first 525 patients, we only found mutations in 4 of the 7 genes that we're testing. We've since found a patient with a DJ1 mutation, but still that's only 5 out of the 7 genes, and we think these are the 7 most common genetic forms of Parkinson's. And then just to comment a little bit about these variants of uncertain significance, the laboratory has identified 43 different variants of unknown significance in 50 patients. Most of those were variants in the LRRK2 gene. And this just tells me that the basic science researchers need to get cracking to help us understand, do these variants of unknown significance lead to overactivity of that kinase enzyme? Do they lead to the pathologic change that we associate with Parkinson's disease? And then a smattering of variants of unknown significance have been identified in these other genes. So that's what we know so far. It's been a fascinating study. What about resources available to you as a person with Parkinson's or a family member? This was, again, resources I listed primarily for the docs, but I think there's no reason that people with Parkinson's and their families can't look up. These are largely online things. So Gene Reviews, I mentioned before, as a wonderful resource that talks about genetic forms of all kinds of different conditions, not just neurologic diseases. The Movement Disorder Society, which is sort of an international organization of people interested in Parkinson's, has an effort to sort of curate these different gene mutations. One of the challenges is, how do you decide when a variant of uncertain significance is now thought to be significant? And there is an effort afoot to really pull together global results of gene tests and patients and mutations, something called the ClinGen-PD Curation Panel, CGPDCP. There's an exciting group to be in if you ever wanted to be in one. So that's also led by Dr. Alcalay, who's the lead investigator in the PD gene study. So that's our effort as clinicians, doctors, scientists, to help determine when a variant is known to be significant. There's another effort called GP2, the Global Parkinson's Genetics Program, that is an effort to fill the gaps where we really don't know much about the genetics of Parkinson's in Africa, in native populations in South America, and Asian populations. There's a Parkinson Study Group, Genetics and Environment Working Group, which for some reason they asked me to be the chair of this year. And one of the things we're going to be working on over the next year is educational materials for doctors and actually genetic counselors, so that we can provide accurate information to patients and families. And then genetic counselors are always a good resource, both for doctors and then also for patients and families. What they do for a living is to try to unpack and describe genetic information to patients and families in a way that's understandable. So that's all I have to say, and we can take some questions for a few minutes.
Thank you, Dr. Nance. As you mentioned, the spelling of that patient's last name, how you had deleted that was a gene mutation. When does this gene mutation occur? Is it in utero, after birth? Can it be environmental causes?
Yeah, so the gene mutations that we're talking about are all things that are present in the very first cell that made you. So we're not talking about mutations in genes occurring during your childhood or your adult lifetime. Certainly things that you're exposed to in the environment can affect genes. We often think of those as being gene changes that can lead to a cell becoming cancerous, but we don't think of that as a gene change that leads to Parkinson's disease. So these gene mutations that we're talking about and that we're analyzing were all present at birth. It is possible for you to be the first person in the family to have that particular gene mutation. So gene mutations often occur during the formation of eggs and sperm. So the parent's genes were normal, but the parent passes on an egg to the child that has a mutation in a particular gene, or the sperm cell has a mutation. Now, it's also possible, as in the case with Christine, where the uncle and the grandmother also had Parkinson's, that there was a gene mutation present in that grandparent, in that parent, that then was passed on to the child.
Okay, thanks for clarifying.
Yep.
So the treatment is ongoing, but there's no easy way of cutting out that abnormal gene or inject normal gene into the brain.
So that so gene therapy is something that is talked about a lot. It's being done for certain genetic diseases. And actually, there's inserting a normal gene into the brain. There's also, so in the case of the LRRK2 gene, where it turns out that the mutation causes an overexuberant production of that kinase enzyme, or maybe the kinase enzyme is produced in a normal amount, but it just functions. It's like me with too much coffee. I'm still me, but I've had too much coffee and I'm just overactive. So one of the treatments on that panel that I showed, or the table I showed of LRRK2 trials, is something called an antisense oligonucleotide, which is not quite injecting a gene, but it's sort of, in a sense, injecting an anti-gene to kind of turn off that gene that is making an overactive protein. So yes, there is actually a lot of work at can you turn off a gene that's overactive, or even if the gene isn't overactive, if it's spewing out an abnormal protein. So actually the Lewy body, that is the histologic hallmark of Parkinson's, is full of a protein called synuclein. Well, one of the genetic forms of Parkinson's is a mutation in the synuclein gene. So people with synuclein-related Parkinson's have one abnormal gene and one normal gene. Well, the abnormal gene spews out this abnormal synuclein protein that sort of crumbles and falls apart and gets stored in these big sticky blobs inside the cell and actively damages the cell. Well, if you could turn off that abnormal gene, keep it from spewing out that abnormal protein without screwing up the normal gene, then that person would only make normal synuclein protein. Would you prevent synuclein-related Parkinson's disease? So that is being tried in a different disease called Huntington's disease, where everybody with Huntington's has a mutation in the Huntington gene that spews out an abnormal Huntington protein that forms these big blobs in the cell that kind of gum up the cell and make it sick. But people with Huntington's also have a normal copy of the gene. So there are currently several research studies going on turning off or blocking the abnormal Huntington gene. And hopefully then, if you only make normal protein, then you won't get Huntington's disease. The same kind of treatment could be applied to synuclein.
Okay, thank you. That kind of goes right into the next question. We've received many questions about atypical Parkinson and Parkinsonism. Does this research relate to those conditions?
So depends on how you define atypical Parkinsonism. I would argue that synuclein and potentially GBA mutations do lead to can in some people lead to something that you would recognize as a more rapidly progressive form of Parkinson's that may have additional symptoms. And that may overlap a little bit with what some doctors might call atypical Parkinson's or might call Parkinson's plus. There are different genes that seem to be involved in conditions like PSP or frontotemporal dementia. So that's a sort of completely different set of genes that are also under intense study.
Okay.
But I'm sort of focusing more on the genes that kind of get lumped more into the Parkinson's, or,
Okay.
maybe a given person has Parkinson's plus, but it's not quite so obvious as to call it frontotemporal dementia or PSP.
What about MSA? Would that fit in that other
MSA
Parkinson plus?
Yes. So
Multiple system atrophy.
MSA, right, stands for multiple systems atrophy. And again, I personally struggle a little bit with where do you draw the line to say this person has MSA and that person has Parkinson's with a bunch of other stuff mixed in, but now it's crossed the line that's MSA. So I think some of these genes that we're talking about, again, GBA, synuclein, may lead to, in a given patient, symptoms that sort of overlap with the phenotype of MSA. but mostly we're talking about this sort of large pool of patients that come into a Parkinson's clinic labeled as something relatively close to Parkinson's.
Movement disorder. Okay.
Yeah.
Okay. So this next question is similar, and will try my best to spell out. There's a correlation between homozygous MTHFR C665T genetic deficit with neuropathy and PD.
Yeah, so MHTFR actually MTHFR, methylene tetrahydrofolate reductase, is the name of the enzyme. It is a little easier to say MTHFR. So that's an enzyme that has to do with how the body handles a particular chemical, a particular amino acid called homocysteine. So people who have a mutation in that particular gene end up with a buildup of homocysteine in the blood, and you can detect it with a blood test. And that people with something like 15% of white people and 25% of Hispanic people have a variant in the MTHFR gene. So it's a really common variant. Do you call it a mutation, or do you call it just a common variant that leads those people to have an elevated level of homocysteine? That has nothing to do with Parkinson's disease, but another thing that can raise your homocysteine levels is if you are deficient in certain B vitamins like folic acid and thiamine. And we know that people with Parkinson's, if you give them levodopa, your body uses up folic acid as it metabolizes levodopa. And so so you could imagine that if you're using up folic acid, metabolizing the levodopa that you're taking for your Parkinson's, you may end up with a high homocysteine level, because lack of folic acid leads to a high homocysteine level. If you also have an MTHFR variant that raises your homocysteine level, you may be even more likely to have an elevated homocysteine level. This is what leads a lot of doctors to say, take some extra B vitamins if you have Parkinson's and you're being treated with levodopa. So just acknowledging the fact that you use up B vitamins as you metabolize levodopa, take a B complex vitamin so you're actually supplying yourself a little bit extra of that, of those vitamins. That's also the typical treatment for people with the MTHFR deficiency, is take more B vitamins. So it's not that MTHFR causes Parkinson's, but both conditions may lead to elevated homocysteine levels, which are bad for the nerves and bad for other things.
Okay, thank you, Dr. Nance. I'm going to shift gears and we're going to go to more genetic testing questions. A lot of questions about, should I get it? Can people without the Parkinson's diagnosis get it? Should they get it? My husband has Parkinson's. Should our son, as he really wants to know? I know you touched on some of these pieces in your presentation, but yeah, what are your go-to guidelines or thoughts?
Yep. So this is exactly what our study is hoping to, I mean, these are the questions that we want to hear. So as I said, we've been kind of overwhelmed with the number of people who have Parkinson's who want to go get genetic testing. And it's a lot of, you test 1,000 people, you'll get 100 people testing positive. So it's that's 900 people who get a gene test and don't know anything more at the end of their gene test than they did before they went in. And so that sometimes is frustrating to people to, spend this time, enroll in the study, and a month later you find out nothing. Or heaven forbid you go and just pay for a gene test. And it costs $1,000 or however much it costs. And at the end it's normal. And you feel like, well, that didn't tell me anything. But those 100 people will find out that they do have a gene mutation, and that puts them into a different category, both in terms of research, understanding why they have Parkinson's, and then risk to family members that is altered by knowing that there is a specific gene in the family. We barely know what to tell the people who have Parkinson's what the gene results mean. It's even harder to explain to, let's say you have a 60-year-old guy, let's say Paul, who came in and he turns out to have a mutation in both GBA and Parkin. Well, each of his children has a 50-50 chance of inheriting either the normal or the abnormal GBA gene. Each of his children also has a 50-50 chance of inheriting the abnormal Parkin gene. But we don't know, I may well have a mutation in the Parkin gene and not know it. It doesn't 100% for sure cause Parkinson's. We're not even sure. We think maybe it increases my risk of getting Parkinson's, but I don't know what it increases it to. My risk currently is 3%. Maybe it increases it to 8%. Well, is that helpful information to me to know that I have a gene that increases my risk to 8%? And the GBA is the same issue, that some of the GBA mutations do not with certainty lead to Parkinson's. They increase the potential to get Parkinson's up to 10% or 12%. Well, is that useful information for your 30-year-old child to find out now that they've got a GBA mutation that may or may not ever lead to Parkinson's disease, increases the risk to 10%. The downside is that insurance companies and employers don't have a category for has a gene that may never cause a disease. They have a category for increased risk or no risk or normal risk. And insurance companies are likely to put you in that increased risk group. And your employer, if it's between you and me for the promotion, and they find out I have a GBA mutation and however they find that out and you don't, well, guess who's going to get the promotion? What about your own standing within the family? The oldest son has always been the most important, the designated heir, and then he turns out to have that GBA mutation, and the second born son is found to not have the GBA mutation. Does it subtly shift their role within the family? So those are all things you have to think about when you start testing an asymptomatic person. There is interest, we were just talking about it in our committee meeting the other day, about asking the children, the siblings and children, the at-risk, the relatives of people who have genetic forms of Parkinson's, are you interested in getting a gene test or not? Not that we're promising that you're going to get it at all. We're not ready to do that. We don't have we barely can test all the people with Parkinson's who aren't tested, but are you interested in having a gene test? And if so, why? And if not, why not? And so, the minute the testing is available, we know that other people in the family are going to want to know, should I be tested? And then the next thing down from that is, well, okay, now I'm 30 years old and I know I have the GBA gene. Should I have prenatal testing? Should I test my unborn baby to find out if that baby is going to have that Parkinson's gene? What do you think of that idea? It spirals into family members pretty quickly, but we are interested in thinking about it, not necessarily doing testing right this minute. But
more to come down the road.
Yeah.
Okay. I have one last question. How can genetic findings help me, or could genetic findings help me reverse my trajectory of my Parkinson's disease?
Yeah, so you faded out, but the question was, how can genetic testing help me change the trajectory of my Parkinson's, treat my disease, slow it down, stop it, reverse it? And the answer today is it doesn't. That's not where we're at yet with the genetic testing. But if we find out you have a LRRK2 mutation, you could potentially be in the study that's developing treatments specific for LRRK2 Parkinson's. And if those treatments actually work, then that might change the course of your disease. So we're at the very early stages in the genetics of Parkinson's, where we're just able to identify people with gene mutations. But obviously what we want to do is develop treatments that based on the knowing about the gene. We're not quite there yet.
Great. Hopeful answers. Thank you, Dr. Nance, so much for your time this morning. I really appreciate your expertise and taking the time to share it with the Parkinson's community.
Yeah, it's been my pleasure. Thank you. And thanks to all the listeners.
Yes. All right, well, have a good rest of the morning, and we're going to move on to our next speaker. I am pleased to introduce our second presenter, Dr. Rodolfo Savica, consultant and associate professor of neurology at the Mayo Clinic in Rochester, Minnesota. He studies the early life predictors of neurodegeneration and the mechanisms that lead to neurodegenerative diseases such as Parkinson's disease, dementia, and Lewy body dementia. Welcome, Dr. Savica.
Hello, hi, hello. Do you hear me? Yes, fantastic.
Yes, go ahead and share your slides.
Yeah, but I want to make sure you hear me. You hear me? I guess you do. Okay, so excellent. So thanks for having me. It's a real pleasure to be here and be talking to you. I'm always have the opportunity to and the pleasure to spend time talking to you at the Parkinson Foundation. I love to talk to everyone that is interested in Parkinson's disease, especially people that have either patients or family members of the patients. Today, we're going to try to talk a little about some of the very relevant aspects of Parkinson's disease that are related to the frequency and on how frequent, how common is this condition in the population, and how common is in Southeast Minnesota, basically how common is in the Midwest, and how this information can be adopted to know more about the disease per se, to know more about what to expect, the prognosis, what to see in the future. Erin, just double checking, do you see me as well, or you're just see the slides?
Yes, we see you, Dr. Savica. You could share your slides though. It looks like we're not able to see them just yet.
Oh, it's very interesting because I see the slides, but I don't see anything else. Okay, just a sec. I'm sorry for this problem. It would be, I think, this one. Do you see the slides now?
Yes, and you just have to go to presentation.
Perfect. I want just to make sure, okay, because I had a faulty image. Now it's good. And you see me as well, correct?
Yes, you look perfect.
Perfect. Thanks. You're very kind to say I look perfect. Thanks. Okay. So today we're going to discuss indeed on how frequent is the condition and what this means in terms of how can this data can guide us in knowing what to do next. I don't have any relevant disclosure as far as I can tell, but those are the learning objectives of today. Knowing some of the diagnostic features, see the current epidemiology, and support the current theories on Parkinson's disease and then the progression of that. First of all, we have to clarify two important points. We're going to discuss about incidence and prevalence. Those are two different concepts. Incidence represent the number of new cases of one given disease in a given time. So in this case, we're going to talk about incidence as number of new cases of Parkinson's disease every year in 100,000 people. So it's important to define this concept because prevalence on the other hand is the total number of cases in a specific time. So incidence represents a more dynamic approach to tell what are the new cases that are occurring every year. Prevalence is something that is static, tells in this time, this is the snapshot of that particular moment. So when we talk about incidence in Parkinson's disease, we know that the number of new cases of Parkinson will increase dramatically in the next decades. There's a number of studies that have adopted and used incidence to be looking at Parkinson's disease. However, sometimes the studies are incomplete because we are not able to identify all the different type of Parkinson or Parkinsonism, all the different type of Parkinson, or include all the population. We have the opportunity here in Southeast Minnesota, in Rochester, where I currently reside, to have this system. We're going to talk more called the Rochester Epidemiology Project. But for example, these slides talk about a study looking at all the new cases of Parkinson's disease that occurred in Olmsted County, Minnesota, from 1976 to 1990. What we were seeing that there were 13 cases every year, 13 cases every year, 13 new cases every year of Parkinson's disease. What we were seeing from 1976 to 1990, that the number of cases increased as we were getting older, and we are expecting that as we get older, this Parkinson's disease, as any other degenerative disease, seem to get more common as we get older. So aging is a factor, but also, and this is a very important thing, we were seeing a sex difference here, where men were absolutely more affected than women. There was a study that obviously looked at an era that is not the current era. Look at an era from 1976 to 1990. Now we know more about Parkinson, we know more about Parkinsonism. We have much better ability to understand and to diagnose the patients with this condition. Therefore, I personally ran this other study in the same population from 1991 to 2005. And what is this population? This is the Rochester Epidemiology Project, a system that allows us to identify the entire population of the Olmsted County, about 115,000 people. And we are able to identify the entire medical history from the moment they were born, most of the time, to the moment they were dead. And we went through a number of records. We look at all the medical records of all the patients that have been seen within Olmsted County, not only in the Mayo Clinic, but also in the local hospital, the Olmsted Medical Center. And we look at all the different types of Parkinsonism and all the different types of response to treatment and so forth. This was possible because of the Rochester Epidemiology Project. There is this system that I want to show you because it's incredibly powerful and provided an enormous amount of information. And the beauty is that it's located here in the Midwest, in Southeast Minnesota. This is the system. Basically, every medical record has a code. Every code is linked together. So if an individual has been seen within the system by different providers, all the providers will share the same code that identify an individual. We can see exactly who is living in Olmsted County. And then we are able to retrieve these codes and identify a person with or without a given disease. Today I'm using Parkinson's disease, but this can be done for any diseases. And this can translate in epidemiological studies that can improve the medical practice, the public health, and can improve the quality of the medical record. The beauty is that now we moved from Olmsted County to the 6 counties surrounding us, to the 20 counties surrounding us. So we are expanding to a larger population encompassing about 500,000 individuals that we can study, can explore. Obviously, is a lot of archives. I remember when I was reviewing them, I went to thousands of charts. This is a photo, thousands of charts. But in this particular case, we look in Parkinson's disease. Actually, I'm sorry, we look at all Parkinsonism, and I have a list here of all the different criteria just for you to know. Parkinson's disease, dementia Lewy bodies, Parkinson's dementia, secondary Parkinsonism, but also other forms such as drug-induced, MSA, PSP, CBS, ALS in Parkinson's, and so on, condition that we already talked during Dr. Nance's Q&A section. So not just Parkinson, but all of them. So what we reviewed 5,000, I reviewed, Rodolfo Savica reviewed about 5,000 charts, which is a lot of them. And we identified 542 cases of all sorts of Parkinsonism. But what we were able to identify, this is important, I'm sorry, I skipped a few of them because this is important. We identify the incidence, so the number of new cases every year, every 100,000 persons, of all Parkinsonism is about 29. and Parkinson's disease is 14.2. When we then group together in people that recognize, in patients that recognize synucleinopathy, so Parkinson's disease, dementia Lewy bodies, Parkinson's dementia, and MSA together, that is 21. Once you look at tau, which is this other protein that encompasses for PSP, CBS, and few others, that is rare, kind of rare, 1.1. But what we saw that is very important, this is very important. This graph represents the curve of the new cases of Parkinson through the years for age. You can see that there is a clear difference between men and women for Parkinsonism and for Parkinson's disease. And you can see there is a clear divergence at around 60 years of age between when the two curves are completely divided from each other. And in fact, what we identify that men are almost doubled compared to women. So there's about 27 cases every year between men, and 15.4 are women, so almost double up. And you can see on how the incidence, the new cases of DLB, PDD, MSA, so what we talk about atypical Parkinsonism is way lower than Parkinson's disease, as expected. And another important point is that when we group together the different proteins, when we group together Parkinson's disease, dementia Lewy bodies, Parkinson's dementia, and MSA, we have a curve that is very similar to what we were seeing in Parkinson's disease. What does it mean? It means that for sure, we know that the cases are increasing with age. We know the men and women are different. And I will push this concept even further. They're not just different in terms of frequency of disease, incidence of disease, but also we have some data now that suggests that men and women are very much different also in terms of response to treatment, prognosis, and so forth. We will see this a little bit forward. What is important is, I want to mention this because we were talking about that before. There are other forms of Parkinsonism that can be seen. For example, drug-induced Parkinsonism here. Those are rarer, but they're present. It's about 1.9. So there are about 2 cases every 100,000 patients every year. And that is a different condition compared to Parkinson, because Parkinson disease induced by a drug of any sort usually is more common in women. So on the contrary, what we see in Parkinson's disease, it usually causes when there's a lot of drugs together, and there's been a decrease from 1976 to 1990 to the most recent cohort, which is the opposite of what we see in Parkinson's disease. Why? Exactly for what I told you before. We know more about this condition, so we avoided medications such as antipsychotics that were heavily used in the recent past that can cause people to look more Parkinsonian. So if in Parkinson's disease we see a spike of the numbers, in drug-induced Parkinson's disease we see a decline of the numbers. And one thing is important, you may all know that to make a diagnosis of Parkinson's disease or Parkinsonism, we use clinical symptoms, but we need to do an autopsy to make sure. And actually, our concordance with autopsy, so some of these patients were able to go to an autopsy. We noticed that indeed our concordance is pretty good. We are 81% more or less correct between our clinical diagnosis and our final autoptic diagnosis, which is, I would say, a good number. It's not great, but it's a good number. So regarding the incidence, so new cases every year of a given disease in a given time, what we found? Well, that all Parkinsonism increases with age. The men are significantly higher than women, with the exception of drug-induced Parkinson's disease. The PD, obviously, Parkinson's disease is the most common form of Parkinson's disease. And then there's this divergence between men and women that is very, very important. Another problem that sometimes we run into is that, and Dr. Nance also talked about it, sometimes when we deal with Parkinson's disease, we deal also with conditions that are similar to Parkinson, such as, for example, dementia Lewy bodies, or a condition called Parkinson's disease dementia. This is happening when the dementia, the cognitive decline, occurs quite early in the course of the disease. And it's been taught, it's been known that these conditions are slightly different. However, they're very similar, but they're slightly different. In fact, the incidence, it's a little bit different, I would say. As you can see, is lower. It's 3.5 cases per 100,000 persons per year. But again, same story as in Parkinson's disease. There's an increase with age and is higher in men compared to women, way higher in men compared to women. You can see this yourself. How with dementia Lewy bodies especially, there's a clear divergence of the curve that occur around the age of 60 to 69. In Parkinson's disease dementia, there's a divergence but occur later on in life. Remember, Parkinson's dementia is a condition when also there's some Alzheimer condition together mixing them in the mix of proteins. And when we combine these two together, the curve resembles dramatically the same curve that we see in Parkinson's disease. So what we are learning about that, we are learning, we're going to talk about prevalence in a minute. We are learning that all the diseases associated, related, similar to Parkinson's disease. So Parkinson's disease, dementia bodies, Parkinson's disease, dementia, they are having the same behavior in the population. They are increasing with age, and they are way more common in men compared to women. What about prevalence? Prevalence, again, is the total number of patients in a specific day, in a specific time. We did the same study, and we found the important results that we can summarize in a very easy way. The prevalence is 2% after the age of 70. The prevalence of Parkinson's disease is 2% after the age of 70. So this means that there are two cases of Parkinson's disease every 100 patients, or every 100 persons that are in a specific place after the age of 70. We also calculated something very important that has very important clinical implication. There would be a doubling of the case of Parkinson's disease without dementia in 2060, and a tripling of the case of Parkinson with dementia in the United States in 2060. It's telling indeed on how we are seeing an increased number of cases. Why is that? The jury is still out there. There are some theories about it, but clearly we are seeing an increase of all the cases of Parkinson's disease. When we look at the curves are similar to what I show you in incidence. You see this clear divergence between men and women that is clear, is there, is identifiable. And the same curve you can see in people that have Parkinson's disease, but that they also have dementia or mild cognitive impairment. They're very similar. There's this divergence between men and women. And as we get older, we see an increase of the risk. Again, just for a graphic representation, I want to show you on how this is all types of Parkinson's disease with or without dementia. And this is calendar years in the future. This is our estimate. You can see on how there would be a constant increase up to 2060 when we're going to have a doubling and actually a tripling when we talk about dementia. That is very important. This is telling that we are seeing a massive increment of the cases. And we are still yet to understand why. Again, there's many theories. Some of them are very complex. has to do also some of them with the evolution or the way our brains is reacting to the environment. It has to do with some of the genetic mutation interacting with the environment. So there's many things there. But when we look at the literature, and we look specifically at people that have cognitive impairment, which is one of the biggest fears, one of the fear that we have, I have Parkinson, I will develop dementia. The literature is very variable. You see that there's the presence of cognitive decline can occur from 9% to 84%. A lot depends on the definition, a lot depends on how we look into that. We had a study that shows it's about 26%, but using some different criteria, and I want to show this is a very interesting study. We look changing cutoff of a specific test, that is the MoCA, one of the most used tests done at the bedside, or the MMSE, change completely the frequency. And let me tell you, the researcher, we are still debating on what to use. So there is clearly a variability on how things have been used. Our study, the one we did, we noticed that about 42% of patients develop cognitive impairment of any sort. Some of them had severe dementia, some of them had just minimal decline. And it's important to say the median age of diagnosis of the impairment was when at 80. So clearly patients were a little bit older when they started the impairment. But after the diagnosis at 80, there was a median death of about 5 years. But clearly at 80, regardless, the life expectancy is about 86, 87 in US. So it's not that far from the life expectancy. One thing that is important that I want to mention in our population, that about 77% of patients that had cognitive impairment and Parkinson's disease required to go to a nursing home. And this is an important thing because it's telling on how the moment the cognitive impairment starts, there's a decline. But remember, these patients were older. So again, if you're 80 or 85, there's a risk already to go to a nursing home regardless. And this is exactly what we see. The incidence of the survival and the time for Parkinson's disease with cognitive impairment, you can see there's a constant increment. And I want to show this data to show on how relevant are these data for our public health and to push the legislator to provide more funds for this research that is needed in order to face a public health crisis that we're going to see in the next future. One question that many people could ask at this point is that, okay, you're telling that the disease is increasing now, but what about compared to the past? Is increased compared to the past, and why? Well, we were able to combine two studies, done still in Olmsted County, a study done from 1976 to 1991, and a study done from 1991 to 2005. So we have 30 years of observation. We combine two studies, same population, same geographic area, comparable clinical criteria, and 30 years of observation, which is a huge number of years that we can use. We had about 900 cases of Parkinson's disease. And we compare change from the first decade to the last decade. Well, you can see yourself. The incidence change. The incidence of Parkinson's disease increased from 10 to 18 and doubled in men, whereas it just increased, quote, quote, just a few points in women. You can see the same in Parkinsonism of all type, 4 or 5 points in women, almost double in men. But it's important because we are noticing on how from 1976 to 1991, compared to a more recent era to 2005, there's a double of the cases. And when I look at this is the 3 decades, you can see on how there's a spike of increment with the exception of drug-induced Parkinson's disease, where women were more affected, and there are good reasons why this is the case. And there is a decline, as I was telling you before. So it is very important. As well as we see another important little detail. The age group that seemed to have the larger spike of increment is 80 to 99. In other words, people that were between 80 and 99 years old were the ones that were noticing an increment. Maybe because now people are tend to live a little bit longer, so they have time to develop the disease. But you can see this is present either in men or in women. One thing that to me was crucial and important, and it was very interesting, especially in light of what we know now, in light of the current pandemic, and that was a study that we published some years ago, I think 5 or 6 years ago. What we did, we looked at what are called the birth cohort. What are the birth cohorts? So basically, we identify 10 years from 1900 to 1960. 10 years, so 1900 to 1909, 1910 to 1919, and so forth. What are they? So we look on when the people were born to see whether or not they had a later life increased of having Parkinson's disease. Sometimes this can tell us about what kind of exposure to things that occurred. Well, we notice just one interesting change that you can see almost constantly in Parkinson's disease, in men and in women. You see this yellow line. This yellow line are people that were born in 1920. What happened between 1915 to 1918 to 1999? 1919, what happened? Well, Spanish flu. There was a pandemic. There was the Spanish flu. So the entire idea that explained this is possible that people that were exposed in the womb, or even better, people that were conceived by parents in the pandemic were somehow exposed to some factors, maybe infectious, we don't know what, that increase their future risk 70 years later, 6 years later, to have Parkinson's disease. And this is important for now, because we are dealing with a pandemic, and we don't know, despite we may know some of the immediate consequences. We do not know this exposure, and I'm talking here straight to the exposure to the virus. We don't know the exposure. What can it cause to us in 78 years? So this is important thing to be saying. So incidence changes over time. So new cases over time, dramatic increase incidence in PD and Parkinsonism in people that are 78 years old and above. Drug-induced Parkinsonism reduces, but clearly men are more affected than women. This data can provide us also additional information that are very important. Those are survival curves. What are the survival curves? Those are the curves that show people on how they die through time, compared to a general population. So the yellow are patients with Parkinson's disease, and MSA, dementia Lewy bodies, and Parkinson's disease dementia. And in kind of bluish, this is the cohort of reference. So a number of controls that are age and sex matched. And the idea is that if the disease does not have any effect in the survival, so in the life expectancy, the two curves will be next to each other. And as you can see, they are next to each other for the first, about 5-6 years. Then they start to diverge. And it's fair to say that people with Parkinson's disease may have about 2 years of reduction of their life expectancy compared to the general population. Things are slightly different between dementia Lewy bodies, Parkinson's dementia, and MSA, so other forms, when the disease is a bit more aggressive, causing us way stronger reduction of the condition. But clearly, everybody's different. Clearly, what we know and we use this concept to generalize, they don't necessarily apply to the single individual. And clearly, the diseases are different. I want to show you the survival according to the symptoms of onset. This is quite crowded, but I want to tell you. What we know, what we see, is that if somebody has tremor at the onset of Parkinson's disease, the prognosis, the survival is way better compared to somebody that did not have tremor. And I will add on, somebody has tremor and is a woman. The survival and the prognosis is much better compared to men, generally speaking, compared to men without tremor. So what is telling this data are telling us, and this is why it's important to have this large data set, is telling us that the different clinical symptoms of Parkinson's disease are telling something different. And this is a little bit what Dr. Nance told, right? So the way the disease behaves, the way the disease manifests, is a reflection on the way we are responding to disease, on the way our genetic background is, on the way our environment interacts with the genetics, and how the disease is developing. So having tremor represents a different way our own brain is responding to a particular agent and disease, and has different implications in terms of prognosis compared to somebody that doesn't have tremor. I want to change gear a moment. This is an important concept. There are other factors that occur before Parkinson starts. Those are some of what we call the non-motor symptoms: anosmia, Drickman behavior disorder, autonomy impairment, and so forth. And I want to show this is a very important concept. I want to show what happens before, because this has to do with the way we see the disease, the motor symptoms, what happens before the tremor, the stiffness, the falls. A lot of things can happen before, and those are already likely early manifestations of the disease that can occur 20, 30, 40 years before in the typical case of Parkinson's disease. But that expression of the disease, the occurrence of the disease, depends on a number of other things, including risk factors that are green here, and protective factors that, together with our genetic predisposition, with the way the brain developed in the womb as our mother was pregnant of ourselves, they're acting together, getting this complex relationship, realizing different diseases, different way the disease behave. In fact, we have a number of preclinical symptoms, and clinical syndrome. Number of preclinical symptoms that combined with clinical symptoms, they form what? Clinical syndromes. But you realize the number of combination is finite, is not infinite, is finite, and depends a lot on the way we respond. That's why our population studies can be important and can guide us, but does not represent necessarily the single individual that has some specific differences compared to somebody else. I think my time is almost done, so I will skip some of the live slides. I would like to acknowledge some of my colleagues that are working with me in the last 15 years. And I would like to post this picture today. This is my lab, just because it was a beautiful summer day, and we need this in Southeast Minnesota or in Midwest in general, because it's incredibly cold outside, okay? I'm gonna be around, this is yesterday, I'm gonna be around, no, 3 days ago, I'm gonna be around for questions.
Thank you, Dr. Savica. I've got some questions lined up from registration and a few coming
Erin,
in.
do you mind if, because I have one thing I want to mention right away about one of the previous questions of Dr. about the MHTFR mutation.
Yes, go for it.
Is important one. So I am one of the strong believer about the using B12, folate, and B6. we have some very little data based on this population, but some data that shows that people that are using B12, folate, and B6 and have Parkinson's disease have a slight reduction of about 1 to 2% risk of having dementia. I take it. So every patient that I see, and I start with Parkinson's disease, and I start them on carbidopa, levodopa, they all want to use vitamin B12, folate, B6. But it's important to notice that it's important to have a current dose. So B12 is 2 milligrams every day, folate is 2.5 milligrams every day, and B6 is 25 milligrams every day. I want to mention because this is something that can be important, and I want to link to that. I'm sorry for interrupting.
No, that's good information. Do you think some of our multivitamins might incorporate some of that vitamin B already?
We had to make sure about the dosing. Sometimes the
Okay.
multivitamins that are there, they have them, but they do not have enough B6, B12, and folate.
So really reading the labels of what you've got in the cabinet.
Yep.
Okay. I know that's something I need to work better on, is reading the labels of how much percentage of my daily total I'm actually taking. So that's a good reminder. All right. Question, as you mentioned, some of the causes of Parkinson's, and you mentioned the 1918 Spanish pandemic. Thinking about Olmsted County, do you think there was farming related?
This is a fantastic question. So pesticides have been involved for years and years and years as a possible risk factors for Parkinson's disease. But we all know that not all the farmers that have been exposed to a given pesticides that develop Parkinson's disease. So clearly there is already, and there are some beautiful studies that shows that, needs to be an individual predisposition together with an environmental agent. In this case, it can be pesticides. When together combined, the risk occurs. Now, if it was pesticides only, I say pesticides because farming usually involves pesticides, and especially in the past, they were sprayed without any particular control. But if it was the pesticides only, all the counties, all the governments, the local and federal government made major regulation changes in the last 15 years regarding the use of pesticides and regulating in a much different way. I would expect if it was only related to pesticides, farming associated pesticides, I would have seen a decrease of Parkinson's disease, whereas I don't. So for sure, the role of farming and the role of pesticides has a major role, and we know, and I would never deny that because it's been proven, it's been associated, and it's been seen. But there is clearly something beyond that. And in order for any exposure, can be a trauma, can be pesticides, can be, I can give you another exposure, Agent Orange for the people that are in Vietnam, that maybe are causative of Parkinson's disease or increase the risk, there need be a genetic individual predisposition that cause these risk factors, environmental risk factors to bump up. And also, there must be a protective age. There are protective agents that we are not considering yet. There are protective genetic factors that sometimes there are blocking the risk factors to come up. So is a balance, is a perfect storm that has to be occurring. And a perfect storm that occurs throughout our lifetime is not just one single exposure, is minimal exposure that occurs for long time.
Okay. While you're answering that question, we had a bunch of people asking if you can spell out the different recommendations of the vitamins.
I would definitely. I will write why don't I write in the chat so everybody reads it?
Perfect. Thank you.
I think it's good, okay? So I'm gonna do B12, 2 milligrams, guys. Folate, which is folic acid, folate, I would say folic acid is 2.5 milligrams. And the B6 is 25 every day. Now, guys, they were selling them all together. They still sell all together. It's incredibly expensive, so I never prescribe that. I say to go to Amazon, Costco, wherever you find, and find this one, okay?
Perfect, thank you. All right, going back to the incidents, you said sometimes a traumatic event may cause Parkinson's. Would that be like a severe concussion or like an accident, car accident, or?
So traumatic brain injury, head trauma, has been considered a risk factor and is being recently disputed. As usual, is not the only thing that is needed. Anybody hits a trauma. This is a trauma potentially, right? What I just did. We do it all the time, but we have a skull and we have a mechanism of protection that prevent, and the flooding of the brain that prevents us to have consequences. Clearly, again, same story. If it was only a trauma, I'm expecting every kid that play any sport, every kid that was pushed from down the stairs from their sisters or vice versa would have had the Parkinson's disease. And it's not the case. Clearly, there is an individual genetic predisposition has been proven, shown that people that have some specific genetic determinants and have exposed to a trauma may have an increased risk of having Parkinson's disease. But as usual, we have protective mechanisms that are interplaying with that. Another thing I want to mention, because when we talk about trauma, sometimes we talk also about surgical traumas, right? People are going to the surgeon to do a hip or knee replacements, and then they notice changes after that. I'm pretty sure that many people that are listening can say that. Well, the data are not great about this particular phenomenon, but we know that every event that causes a cellular stress, it can be even a massive death in the family, a massive loss, a heartbreaking because your boyfriend or girlfriend, break up with you. Something that causes a major, massive cellular stress. So at the cellular level, can enhance something that was going to brew at one point. So surgery in this case has this kind of role. The non-anesthesia, but the stress that your body is going on during a surgery, can be a knee replacement, it can be a traumatic surgery, can cause this problem, okay? Can enhance, can push something that was going to develop anyway.
Interesting how molecular, how cellular it goes down to. That's amazing. Speaking of some of the questions we had with Dr. Nance about any commonalities, is there any connection or genetic connection between Parkinson's and MS or ALS?
So with ALS, there are very, very rare form of Parkinson disease, Parkinsonism, so not Parkinson disease, Parkinsonism, that can be associated with ALS, that have sometimes some very specific genetic determinants, sometimes runs in the family, sometimes it's not, but is a very rare situation. Doesn't mean that we are not seeing it, is that in the population is not common. With MS, it's not proven. MS is a disease that has some inflammatory component, is an autoimmune disease. Despite in Parkinson's disease, you may see an immune response of some sort because of the degeneration of the cells. So in other words, if the cells start to decay, my first reaction as a neuron is to call the help from the inflammatory cells that are fighting this decay to respond. Despite there's this in Parkinson's disease, the inflammation levels are nowhere near what we see in MS. And the two conditions are quite different, affecting different group of cells in the brain. As far as I'm aware, there's never been a clear link between MS and Parkinson's disease. Now, if the multiple sclerosis, plaques, and the damage associated with multiple sclerosis is affecting the same centers that are affected in Parkinson's disease with a different mechanism, clearly the patient that has MS can have similar symptoms like Parkinson's disease. But this is valid also for a stroke. If I'm so unlucky that I get a stroke in my basal ganglia, where the cells that are dying in Parkinson's disease are usually occurring, I will have symptoms that are very similar to Parkinson's disease, but the origin is completely different.
All right, thank you. Thinking back to the case incidence, do you think there's more cases of Parkinson's in the Midwest, or is there a region that's been identified?
No,
I feel like it's kind of spread out everywhere, equal opportunity.
Absolutely so. So first of all, the problem that we have here is that we have some, especially these data are based upon a population that is usually white Caucasian and of Scandinavian origin. So we don't have a lot of minorities because of the way the population has been developed through the years. Now things are changing, but we will see this change later on, not right away. So this means that we can generalize this data mostly for people that are white Caucasian or Northern European origin. However, this kind of trend has been seen everywhere in the world. There's not been a specific population that report a decline. Now, clearly there are some populations, some area of the world where we don't have that good of a amount of data regarding incidence and prevalence. I give you an example. Dr. Nance mentioning sub-Saharan Africa, and it's true. In some African countries, we don't have this great data. In some Asian countries, we don't have this particular great amount of data. But I'm part of several initiatives to study globally the frequency of Parkinson, and everybody's seeing the same thing. Everybody's seeing an increase.
All right. I've got some other questions related to Parkinson's. You willing to chime in?
All right. Well, let's see if I can answer.
All right, a very timely question. Any indication of side effects of the COVID-19 vaccines for Parkinson's patients?
This is good. This is an excellent question. So as far as I'm aware, as far as also the International Movement Disorder Society released a press release and communicated, it should be safe to perform and to obtain the COVID vaccine in people that have Parkinson's disease. In addition, having Parkinson's disease does not necessarily increase the risk of complication for COVID. However, every infection of any sort, whether it's COVID, whether it's pneumonia, whether it's influenza, can worsen the symptoms of Parkinson's disease. And in fact, I always tell to my patients, especially when it's flu seasons, forget about COVID, regardless. I say, hey, if you notice that all of a sudden your symptoms are getting worse, and it's not clear why they're getting worse, go to the ER, or better, try to make sure that you don't have an infection. So it's possible that if somebody's going to COVID vaccine and is having some side effect, as are being reported in the wild, in the population, during that particular day, he or she would not be feeling that great with Parkinson's disease. And I had some patients that did have COVID, and they had COVID. The way COVID presented was that their Parkinson's disease medication were not working very well. So what I told, well, just for now, increase your dose, get over COVID, increase your dose of medication, get over COVID. Once you over COVID, go back to your regular dose. We are still not understanding, but the entire idea is this: any infection, any inflammatory condition can cause worsening of the symptoms. But so far, I recommend to all my patients to be vaccinated. For one reason at least, there will be one less thing that we have to think about it, and one less restriction that you have to impose to yourself to reduce your social distancing. Because in the end, one of the worst things that I'm seeing in my clinic is that people are struggling dramatically with depression and with mood disorder because we are restricted. Our routine is disrupted. So having something that can put you more to a normality would be a good thing.
Thank you. All right, another question. Can you describe dystonia and maybe the difference between Or if people with Parkinson's can have dystonia too, or vice versa?
Sure, dystonia is considered an involuntary contraction that usually is a torsional contraction. So it can be something like this. I'm imitating now my neck twist, or if I stand up, my hand would twist this way, and has to be torsional, okay? There's to be contraction that is torsional and it can be painful. Usually in Parkinson's disease, it's occurring in two moments. It can occur when the medication, usually carbidopa, levodopa, reaches the peak. So 45 minutes to 1 hour after patients are taking, or at times at the end, when the medication is wearing off. And it can be a symptom that either you're taking too much medication or too little medication, depends on when in the day and when, according to the medication, the dystonia is taken. There are some genetic form of Parkinson's disease, and that was Dr. Nance was alluded, when dystonia occurs almost every time, regardless of the dose, but those are specific form of Parkinsonism that are early onset Parkinson or young onset Parkinson. So it's slightly different than the general Parkinson disease. I hope he answered the question. Now, the treatment of that depends on what kind of dystonia, where, and for how long, and what can be done. There's many different treatments that they're going between adjusting the medication dose to Botox injections. Depends on where we are standing, but there's a lot in between these two.
Thank you. Another question, actually several questions related to what are the first steps after diagnosis? Where do you go? Is exercising important? Should you see a therapist? What are your go-to steps for your patients?
Let's say I use myself. I go, let's say let's do the typical scenario, okay? I'm 68, okay? 65, 68. So a bit, not that much, but a little bit older than what I am now. And I've been diagnosed with Parkinson's disease. Clearly, number one, depends what kind of symptoms I have. The first thing that I would recommend, make sure that the symptoms are optimized. Make sure that your physician is taking good care of you and you have minimal restriction caused by your symptoms. So this means taking the right medication, make sure the medication responds well. But after that, and actually even before that, I would recommend always this to my patient. Few kind of rules. Exercise, and I say 30 minutes, 5 times per week of vigorous exercise, something that makes people perspire, sweat. Now, I had some patients say, well, I go to swim, I don't sweat. No, you do. You're swimming, but it doesn't matter, okay? You had to be doing that. So exercise, regular diet. Now, dieting is very important. You hear keto diet, paleo diet, this and that. A regular diet, well-balanced, mostly toward the Mediterranean area, so mostly toward eating not too much butter, not too much, some more carbs, but fresh produce, more fish, olive oil, that is good. I always say also to use flavonoids containing food. So those are food that are purple and blue in nature. So beets, raspberries, eggplants, has been shown that the fruits and vegetables that are purple and blue in nature are having people that are consuming a lot of them are having a slight reduction in the risk of having Parkinson's disease. So I always recommend to use more than that. So these two. Third thing I recommend that seem to be silly. If you're able to exercise, you don't need to do a physical therapist. But if you think that your balance is off, I would recommend repetitive sessions at times every few months to see a physical therapist that can help you and also your spouse to guide, or your companion or your friend or whoever is with you, to guide into correcting the balance. Because the most fear outcome that I have is my patients are falling, are breaking bones, or having a bleed, and God knows what happened afterwards. Fourth thing that I recommend to everyone, pleasure. What does it mean? Search for pleasure. Keep doing things that you like. And it doesn't need to be exotic. Doesn't need to be, I'm going to do bungee jumping from the pyramids in Egypt. No, means I like to walk my dog every day and I will do it. I like to go to Caribou. We are in Midwest, so Caribou, to drink a coffee with my buddy every other Sunday. I don't know, but search for this pleasure moment and live through them very well, because those are the things that are really helping the final outcome. In other words, what is the outcome? Trying to delay the progression. Try to live the life in full. And if you do this, and if patients are having an optimization of their treatment, they can achieve that. I'm sorry, I had to drink a sip of water.
That's just fine.
Good.
All right. We have time for 2 more questions.
Please.
All right. Someone shared that their father has Parkinson's and things are doing well, overcoming challenges, no obvious cognitive impairment. Do you think that could still come beyond what is typical of aging?
Very good. This is an excellent question. So clearly, as we get older, so let's forget about Parkinson. General population, everybody that gets older after the age of 70 to 75, if I open up the brain of people and I look under the microscope, I will see the plaques and tangles of Alzheimer's disease as part of the age. So as we get older, there's this accumulation, and it's part of our neurons, our brain cells are getting older. So for sure, as we get older, there is an accumulation of these proteins that can cause symptoms. So definitely there is a component. But as I mentioned in the lecture, not everybody is having cognitive decline. And sometimes the cognitive decline is mild, minimal. And usually it's not the same decline that you see in Alzheimer's disease. It's slightly different. It's not, I don't remember the names, I forget the events. It's more, I have problems planning things or doing very complex tasks, which is different. Those are different modalities. But if everything is well, people are exercising, people are active, people are socially involved, and patients do not exert symptoms of cognitive decline, or if there is marginal, because maybe this gentleman's father is 82 and now doesn't remember the 10th name of his 10th grandchildren, is okay. It's something that would occur regardless. So it's important to have this message that not everyone with Parkinson's disease would develop cognitive decline. There's a percentage of people doing that, but there's also age that gives this same problem. So it's important to keep an eye on things, talking to your physician every time you go, making sure that there's no changes. Because if there are changes, they can be assessed, addressed, and potentially improved.
Awesome. Last question from a viewer. My son has extreme insomnia. He's 40 and had these issues for 20 years. Is insomnia a symptom of Parkinson's?
The short answer is no. Not that we are aware of. Sleep disorders can precede the onset of Parkinson a few years. But so far, the strongest associated one is living out our dreams. So people that are kicking, yelling, punching, talking to their sleep, they can precede the onset of Parkinson for years, decades at times. Insomnia doesn't seem to be necessarily associated with an increased risk of having Parkinson's disease. Definitely, I would recommend this gentleman to deal with that, because having insomnia is something that can cause problems to the brain health, can cause problems to cognition, can cause problems, not to feel well the next day. But if you tell me, the short answer is no. But it's something to put an eye on for sure.
Okay. All right. Well, that concludes our Q&A. Thank you so much, Dr. Savica, for spending your time with us today and serving the Parkinson's community. Stay warm down there in Rochester.
We'll try. We will try.
Right. It's coming around. We're going to warm up. I know it. All right. Well, that concludes today's program. Thank you so much to Dr. Martha Nance and Dr. Rodolfo Savica for joining us and sharing their time with us. And a big thank you to all of you who were able to join us for today's program. If you're not able, if we were not able to get your questions, because we did have a lot come in, we encourage you to reach out to our helpline or to email them. And we will also send a follow-up email containing our survey. We'd really appreciate how sharing your thoughts on how today's program was, and also help us plan for future programs. So if the time of day or the length of the program was off, please let us know. So we'll send that in the email with a link to today's recording and slides and a few other resources in the next week. I'd like to say thank you to today's sponsor, Amneal, for supporting today's webinar. And lastly, to know we've got an awesome program, awesome programs happening Monday, Wednesday, Friday, and our Parkinson's Health at Home, which we host. Tomorrow is going to be an interactive caregiving show and tell, where we'll hear from you in the caregiving community about your favorite caregiving things. Guest moderators from the University of Kansas Movement Disorders Clinic will welcome care partners from around the country to bring us your proven practices, assisted devices, communications, or coping strategies, or other tips that make life better for your person with Parkinson's and you. To learn more, visit parkinson.org/pdhealth. And lastly, want to make sure you've got the contacts and the resources, because you are not alone. We are here for you. If you have any question, please reach out to our helpline calling 1-800-4PD-INFO or email at helpline@parkinson.org. So any of those questions you had from today's program we did not answer, please reach out to them. You can also order some of our free resources, educational book series, and our hospital safety kit. So thank you again for joining us. Stay safe and stay warm.